Well, thank you for that kind introduction, and it's always an honor to be able to address this crowd at the end of the academic year and kind of just review for you what we've done and our major accomplishments at the Texas Heart Institute. And it's particularly rewarding to be able to pull this talk together with the Perfusion Conference, which is really one of the highlights of our academic year in terms of sort of supporting our School of Perfusion Technology, which was one of the crown jewels of the Texas Heart Institute. I always am struck by this slide, and it's one of the more famous pictures from the Texas Heart Institute of Dr. Cooley operating at a time when there was a national conference of surgeons here in Houston. And I'm sure Dr. Livesay could point out which one is Dr. Cooley. I always have a hard time finding him in that crowd. But I have no specific disclosures related to this talk, except that my niece is getting married today, and if she's watching online, congratulations, Elena. So we've had a busy year, and some of you might have heard about this. So last November, for those of you who don't know, we announced a strategic integration between the Texas Heart Institute and Baylor College of Medicine to create what we believe is a unique, innovative, highly effective, and impactful heart center. And so I wanted to just walk through what this sort of looks like and where we are with some of these things today. And the idea behind this was to put the cardiovascular resources from two storied organizations together to create something that's bigger than the sum of its parts. The goal really is to become a cardiovascular center that's globally recognized for excellence and impact in clinical care, innovation, discovery, and education. And so you can see that the major mission areas of both the Baylor College of Medicine and the Texas Heart Institute in cardiology, cardiac surgery, cardiac anesthesiology, and vascular surgery will be combining over the next couple of years to form this new center called the Texas Heart Institute at Baylor College of Medicine. As we began thinking about the strategic advantages to this relationship, this was a partial list that we came up with, but in many ways the things that we do are in both organizations are outstanding and very complementary. Our research programs have different focuses, our fellowship training programs have different focuses, and our clinical programs serve different constituencies, both locally and regionally, but also nationally and internationally. So it's really bringing these two organizations together that we find to be particularly appealing for the Texas Heart Institute. And I just wanted to highlight for you what this sort of looks like going forward. And I don't want you to look at all the names, but I would like to train your eye on the breadth and the depth of expertise that we have as we begin to pull the Texas Heart Institute and Baylor College of Medicine together. These are the medical specialties in this center, and these are the surgical specialties and specialists in this new center. And I would say that we kicked this off with a rather inauspicious start. We went over to a meeting at Baylor College of Medicine, and the president of the college has a nice conference room. And outside that conference room were these two turkey buzzards. And they were spreading their wings, and I thought, well, this is where interns go to die. But so we took this as sort of a sign maybe that we needed to be careful in the relationship, but I would say that this has gone as well as we could have ever hoped in thinking about how we organize our administrative structures, how we're going to bring the clinical groups and the research groups and the educational programs together. So much more to follow on this, but I think this is a really exciting time for the Texas Heart Institute. This is just a brief timeline of what this integration looks like, and this is simply the first phase of this. We've just completed our strategic plan, which will be presented to the THI board later today. We have put together budgets. We have thought about the programs that we want to emphasize, and we'll be transitioning the THI workforce into Baylor College of Medicine by the end of July. And I just wanted to close this section of this part of my end-of-year review with this picture, and you'll know that Dr. Cooley and Dr. DeBakey started off with a very warm collegial relationship, practicing together, and then for decades separated based on a variety of different factors. But at the end of their lives, came back together and refound a friendship. And I think about this picture frequently as I think about Baylor and the Texas Heart Institute coming together to form something really special, and hopefully something that both of these legends in cardiac surgery and legendary leaders will be proud of. So now on to sort of the rest of the year in review, and I just wanted to focus this on what is our why? Why do we do the things that we do at the Texas Heart Institute? And I'll show you in graphic form over on the left side of the slide, and just remind you that if you look at severity of illness of patients across the United States, there's a metric that we can use called case mix index. It's a nationally accepted metric for how sick the patients are. And you can see that we have the third highest case mix index of any hospital in the United States. And as a tangible example of that is the picture of the person on the right side of the slide, and it's somebody that I'm going to come back to in just a little bit, but this is very similar to many of the patients that we see on the clinical wards that we take care of. So what we do here, whether it's focusing ourselves on clinical excellence, whether it's focusing on innovation or training the next generation of people who will care for the man on the right side of the slide, we're always focused on how are we going to improve the care of patients with cardiovascular illness and cardiovascular disease. Our practice, our employed practice, has gone through a pretty interesting transformation in the last year. We have developed a series of specialty clinics that offer expertise to people coming to seek care, and that expertise is shown in the slide, where we have specialty clinics and specialized providers focused on these areas, and I won't go through all of them for you in this slide. How about the hospital? We put this together for a presentation to a group of insurance brokers from the country of Mexico, but just to highlight the high volumes of cases that are done here. And we've already talked about the complexity, but also the volume of work that's being done. You know, we did over 250 TAVR cases. There are over 8,600 cases being done in the catheterization laboratory at Baylor St. Luke's. We did over 25,000 echoes and nuclear studies and stress tests here, and the cardiac surgeons are remarkably busy, doing more than 3,300 surgical procedures on an annual basis. So it is a high volume, high acuity organization, and I'll fill in the third leg of that triad momentarily. One external measure of our success as a heart center is the U.S. News and World Report rankings, and we can argue about the validity of those. Most centers, when they're doing well, love the U.S. News and World Report rankings, and when you don't do so well, you find all the flaws in that ranking system. But it is at least a publicly facing rank, and we are consistently, except for a year or two, in the top 20 in the country in the U.S. News and World Report rankings, which is sort of a holistic view of the quality and the services provided by specialty. And if you break that U.S. News and World Report ranking down a little bit more granularly, and you looked in this tabular form on the left side of the slide, you can see that this hospital performs very, very well. There are some things that we don't control, like we're not a high-level trauma center, so we lose some points in the ranking for that. But if you look at the things that are within our control, we actually do remarkably well. And then they rank us based on a variety of different procedures that we do here at Baylor St. Luke's. And this is the result of all of the clinical people that work in this environment. You can see we're high performing in every cardiovascular procedure that's ranked. I think that's something that we ought to walk out of this auditorium and be very proud of, that the work that we're doing is impactful and it's recognized on a national level for its excellence. We're also recognized by a variety of different professional societies based on the quality of our programs, and this are a series of recognitions from the American College of Cardiology, acknowledging Baylor St. Luke's Medical Center and the clinical faculty that practice medicine here as being outstanding. We have certificates for high performance in electrophysiology, for chest pain, for heart failure, for TAVR in the cath lab, and we have the ACC National Distinction of Excellence for cardiovascular care. So congratulations and thank you to everyone who walks through the door every day and commits themselves to outstanding care of the patients. I also want to highlight for you some remarkable work that the cardiac surgical team has done looking at their outcomes in isolated coronary artery bypass surgery. And I think if I can just train your eye here and look at this risk-adjusted odds ratio for mortality, a couple of years ago, the program thought that they could do better than this. And a lot of this had to do with patient selection. And what you can see is over the ensuing 2 years, we've dropped our odds ratio for mortality from 1.4 down to 0.8. That's a remarkable change in outcomes for the patients who come here and have isolated bypass surgery. And I think it's a tribute to the concerted efforts of the cardiac surgeons, of our cardiac anesthesiologists, and our cardiac intensivists who are managing a remarkably sick patient population. I'll give a shout out to my colleague, Dr. Civitello, and his colleagues in the heart transplant program. They have done more heart transplants per year in the last year than they've done for the last decade. They did 41 heart transplants in 2024, and they're on target when you look at combined advanced heart failure therapies, including heart transplantation and LVAD therapy. They're 10 cases ahead of what was of last year and what is projected for this year. So that group is working remarkably hard to care for a very vulnerable patient population who has limited options. They've also begun some really important work on on utilizing new strategies for organ preservation during transport, you can see that this is one of the worm preservation machines that are being utilized. We're actually developing another one of these for lungs up in Yixin Wang's lab in conjunction with Chris Chen and Gabe Luer. But these are ways to keep hearts preserved for longer periods of time so that they can be successfully transplanted. The programs have also begun working in a space called donation after cardiac death, where the heart is allowed to stop entirely and remain asystolic for 5 minutes before the heart is reanimated and then used for organ donation. And just again, to show you the numbers of transplants being performed, 41 in heart. Last year, the lung transplant program did 108 lung transplants, which puts them in a very rare space in the United States, one of the highest volume programs in the US for lung transplantation at this hospital. So I wanted to turn, and I know Dr. Frazier was on the stage before me, and Lord knows it's always hard to follow that man. But I wanted to just spend a little bit of time, for those of you who didn't have a chance to see Dr. Frazier's talk, and just tell you a little bit about some of the innovation that's going on at the Texas Heart Institute, both last year and things that will be happening in this calendar year. And I know Dr. Frazier talked to you a little bit about the BiVACOR Total Artificial Heart. This was a device that's been in development at the Texas Heart Institute in conjunction with BiVACOR and Daniel Timms for over a decade. Gone through a large series of animal experiments down in the animal lab, incredible amounts of refinement and retesting and iteration of this device. And it's been remarkably rewarding to take what started off as a really good idea and a very early prototype, and gone through the entire development program at THI to the point that we've now been able to implant this in patients. I agree with Dr. Frazier, who I suspect told you that he doesn't see any failure modes with this device, and he believes that this is a complete game changer in the treatment of patients with advanced biventricular heart failure. This is a magnetically suspended total artificial heart. There's nothing like this on the market today. There's one moving part that's suspended in a maglev system so that there's nothing touching inside these pumps. There's very interesting engineering, electrical engineering, that's balancing that rotor inside the canister. It's measuring the position of that rotor 20,000 times a second and making very subtle little changes that balances the circulation between that that's going into the lungs and that that's going out systemically. So let me fill in a few blanks, and I would guess that Dr. Frazier maybe didn't tell you this story. So we actually were the first center to ever implant one of these in a human being. And we were going to implant this on the day of Hurricane Beryl. And wisely we stopped and postponed the implantation for a day. But this device has now been implanted in 5 individuals in the United States as part of an FDA-approved early feasibility study. It was a bridge to transplant trial, and all of those patients were successfully bridged to the point that they could receive a transplant. The implantation times were relatively short because these patients, by virtue of having a total artificial heart that they could not leave the hospital with, bumped up to the highest priority on the heart transplant waiting list. The next iteration of this device will allow patients to go home and wait for a heart transplant in the comfort of their own home. And that's the device that was implanted in the first out of US patient. It was an Australian person who was at home for almost 100 days before he successfully received a heart transplant. The survival rate so far in these 6 patients is 100%. And we learned a lot about these devices and ways to manage them in a manner that provided very good cardiac output with low filling pressures. This looks like just as we predicted it might look from the animal experiments that were done in this institution. You also probably are well aware of the robust robotic heart surgery program that's being led by Ken Liao. And I always like to walk down to the surgical suite, and because this sign on the left keeps getting updated with these little papers. I think we started off when this was at 500. He's now up, this week was up to 795 robotic heart cases, including the second robotic heart transplant ever performed in the world was done here this calendar year by Dr. Liao and his team. A remarkable change. You can see the incision looks very different from a standard heart transplant with a partial sternotomy and a couple of ports that were used for the robotic arms. And then I want to tell you a little bit about a story that you're going to hear more about. And I think we've talked about this a little bit recently in the context of some other meetings. But this is Jim Martin up on the top right of the slide. And Jim and his lab, some of those people are here today, have been working on trying to understand the molecular signals that turn off cardiac myocytes' ability to divide. So when we're born, essentially we have all the heart muscle cells we will ever get in our whole life. We may get a few more, but not many. They just grow bigger as we grow. And that's why heart attacks are so devastating. You kill those heart muscle cells, and the cells don't have any ability to re-enter the cell cycle and start to divide again and repopulate the dead area of heart muscle. So Dr. Martin and his team have figured out the molecular stop signal that tells those cells to stop dividing. And he's developed a gene therapy to turn off the stop signal so that the cells can re-enter the cell cycle and start to divide again. And if you do this experiment in a series of animals, what you can see over here on the right side of this slide are animals in whom we caused a heart attack in here, and the infarcted heart muscle shown in white and the live muscle is shown in this reddish brown color. So you can see these animals sustained a fairly significant injury to their heart. And when we inject the gene therapy and we wait several months, this is what the heart looks like. You can almost, it's hard to distinguish where the scar is. And so this gene therapy has now been FDA approved for an early feasibility study that we believe will start in June, so next month, here at the Texas Heart Institute at Baylor College of Medicine and Baylor St. Luke's Medical Center. So congratulations to Dr. Martin and his team. Also wanted to just highlight for this group what I think is one of our signature programs. I will argue for you that we have the finest aortic surgical team in the world here. You all are well aware of the incredible contributions that Dr. Caselli has made over his career. He's done more thoracoabdominal aneurysm repairs than any surgeon in the world, and it's thought because of the proliferation of people doing this operation that no one will ever match that number of cases. Mark Moon has a similar kind of experience, not quite the number, but is well recognized internationally for his work in aortic surgery. And earlier this year, Gustavo Oderich was recruited from the University of Texas to come here. And Dr. Oderich is doing remarkably innovative work, doing endovascular aneurysm repairs and arterial repairs using patient-modified grafts. And so this is a very exciting time and will be certainly an area of emphasis in the new THI Center. I don't want to pass by this without acknowledging the incredible work that's been done by our research labs. We've doubled our NIH funding in the last 5 years. We've received some recent awards, including a new R01 for Dr. Martin and Xiao Li that's shown there. And we've gotten continue to get wonderful support from our community and from the foundations that are invested and interested in supporting the research that's going on at THI. In fact, if we go back to the BiVACOR story, you probably heard about many people in the Houston community who are philanthropists who supported that device and its development in the early days. And I also want to highlight what I think is an important feature of the THI research portfolio, and that is the research that we do is always intended to change patients' outcomes. And part of that is taking whatever it is you discover and develop and commercializing it and translating it into something available for patients. And so what you can see in this slide, in a variety of different research domains that we have at THI, the companies that are now working on developing these technologies and where they are in the stage of their testing. But again, I think that this is an important feature, a distinct feature and a unique feature of our research portfolio. Again, the BiVACOR story I've told you about. The gene therapy with YAP Therapeutics is Jim Martin's spin-off company, YAP Therapeutics. And Darren Woodside and Peter Vanderslice and their team have been working in the drug development space for years and have developed a very, very interesting vaccine adjuvant that intensifies the immune response to a vaccine. And it's now being tested as an adjuvant to immunotherapy in patients with drug-resistant melanomas. So they're following the science and applying the same concept that they developed in a cancer therapy. So really exciting work, and congratulations to that team. We're also participating in some other sponsored research. I'm not going to show you all of the trials. Well, I think I am actually in the next slide, but there are a couple that I think are really interesting and I think are very much on the cutting edge. This is a trial that Ajit Nair is focused on in the heart failure group, using CRISPR technology to change the genetic profile of patients who have TTR amyloidosis. I think it's the first trial of its kind using CRISPR technology for this particular ailment. And then Mehdi Razavi is doing some very interesting work, and it's always fun to sort of hang around with Mehdi a little bit because he's always got interesting ideas. But Mehdi has this very interesting idea that he can develop very small wireless pacemaker leads that when they're positioned appropriately in the atria of a human heart, he could defibrillate atrial fibrillation below a patient's pain threshold. And if this actually works, this would be a complete game changer in terms of therapy for atrial fibrillation. And you can see the size of those leads relative to a penny. And so, again, really exciting work that I think is transformational, oftentimes very forward-thinking, and not constrained by current paradigm. I told you I wasn't going to show you all the other research that we're doing, but I guess I am. It's in this slide. So this is some of the sponsored research programs. And I guess I'd like to just highlight for you that while there is some, sort of scientific gain for us in participating in these clinical trials, the people that really win are the patients who have an opportunity to not only participate in clinical research, which has always been shown to improve patient outcomes because they're followed more closely, but they're getting opportunities to be exposed to some of the most cutting-edge technologies. I mean, think about, people go to cancer centers to get the most recent, most contemporary, most promising chemotherapies for their cancer. And they're coming here to get that same opportunity for their heart disease. And then I don't want to walk away from the research program without highlighting these 6 individuals who have been elected into the National Academy of Inventors. And this is a remarkable achievement. It's a great recognition for people who have committed their time and their professional careers to innovation and to advancing science and technology. But this is a metric that is used across the country to acknowledge the importance of translational science and commercialization. And if you look proportionately at the number of academy members that we have at THI relative to the total number, we have the highest number proportionately at the Texas Medical Center. And part of science and investigation is publication. And the professional staff has continued to do a great job in publishing their research findings. We've put out more than 260 papers in the last year. I've put some of the most impactful papers in this slide. I'm not expecting you to read the titles, and I'm not expecting you to read the authors, unless you've recently been to the ophthalmologist. But this is really great work. We're publishing high-impact science in high-impact journals. And I want to close by focusing just a little bit on some of the educational efforts that we have going on. Our CME team works tirelessly to support the Heart Institute in terms of this conference. We've had a series of remarkable speakers at Grand Rounds this past year. But all the other CME programs that we're putting on through the course of the year, our AV team has worked remarkably well and hard to provide great services to the programs that we all enjoy and leverage for our professional learning. Grand Rounds is just staggering to me about how many people watch Grand Rounds. We oftentimes will leave Grand Rounds and we'll go up to the TV studio for a quick conversation with the presenter, and I'll sit down with Ramon and he'll tell me who was watching, what countries were those individuals watching from. And you can see we have people tuning in from around the world to watch THI Grand Rounds. And I think it's really a tribute to the people who are programming this and inviting the speakers and the quality and the content that we're presenting every Friday at noon. And Carrie Sprung and her team have been very good about cataloging this incredible library of content that we generate and putting it on Texas Heart TV as enduring content so that people can go back and continue to learn and oftentimes go back and continue to get continuing medical education credits. So I showed you this picture just a minute ago. And I sort of talked about this in the context of what is our why. This is actually Batson Avey. And Mr. Avey was the first human being in the world to receive the BiVACOR Total Artificial Heart. And Mr. Avey was being cared for by Dr. Civitello and his team. He was clinically not doing well on as much support as we had, and we decided that he would be a very good candidate to receive a BiVACOR Total Artificial Heart. We sat down with Mr. Avey and we walked through the entire development program. This is what we did to get to the point where we were ready to implant this in a human being. This is all the testing we did. These are the fail-safes that we have for you. And he's this wonderfully thoughtful, pensive guy. And he looked at Dr. Civitello and I, and he said, you know, I wish I wasn't the first one. You get it. You're exactly right. I'm sure that's true. But I think it spoke to me in a number of ways, and the trust that he had in his clinical team, in the research that's being done in this organization, and the confidence that this technology that had never been tested in an organism that walked on two legs would get him by to the point that he could be transplanted. And a couple of months later, there's Mr. Avey and his brother out at dinner. So this is a guy who lived through a BiVACOR Total Artificial Heart, lived through a heart transplant, and within a few months looks like a healthy man who's doing well today. And I will just pause and let that sort of sink in for a second. It's the people in this room that do this. And you may not be doing this for the BiVACOR Total Artificial Heart, but you're doing it for some person at the most vulnerable time of their life, are coming to you and relying on you to help them get well again. And I hope that when we walk out of here today and we walk in the front door of whatever hospital that we walk into, that we never lose sight of that important fact, that people are coming to us and trusting us to innovate, to provide excellent, innovative care, and to do it with compassion. So I'm going to just pause and say thanks to you all for everything that you do to make the Texas Heart Institute a remarkable place. And so thanks very much.